This presentation is on chronic obstructive pulmonary disease, also known as COPD, and its relationship to dysphagia. Speech-language pathologists are professionals who work with patients with disorders such as dysphagia, so it is important to understand how COPD is linked to dysphagia in order to properly assess and treat these individuals. The aim of this presentation is to examine the bidirectional relationship between chronic obstructive pulmonary disease, known as COPD, and dysphagia, which is difficulty with swallowing. COPD is a chronic lung disease which impacts lung functioning and leads to symptoms such as coughing, wheezing, and shortness of breath. COPD is progressive in nature, and individuals with COPD experience periods of stable symptoms and periods of exacerbated symptoms. COPD is found to be linked to dysphagia because these individuals have difficulty coordinating swallowing and breathing patterns, and also have been found to have decreased sensation of the pharynx and larynx. Therefore, COPD contributes to the presence of dysphagia. Additionally, dysphagia can be related to the exacerbation periods faced by individuals with COPD. Dysphagia in patients with COPD can lead to aspiration, which can then lead to exacerbation. Research has been conducted in order to better understand the relationship between these two conditions so that professionals can screen at-risk patients before they develop severe health complications. It is important to understand the bidirectional relationship between COPD and dysphagia in order to know how to properly assess and treat these individuals for swallowing impairments. COPD is an umbrella term used to describe progressive lung diseases, including emphysema, chronic bronchitis, and non-reversible asthma. The disease is characterized by increasing breathlessness. The disease is progressive in nature, meaning that it becomes more severe over time, and there is no current cure. There are 4 stages of the condition: mild, moderate, severe, and very severe. As one's amount of lung functioning decreases, they reach a more severe stage of COPD. Symptoms include shortness of breath, frequent coughing, wheezing, and tightness of the chest. The number one cause of COPD is smoking. The condition most often occurs in individuals ages 40 or older. Genetics do play a role in the development of COPD, as not all individuals who smoke have or will have COPD, and not all individuals with COPD have smoked. However, according to the COPD Foundation, 90% of individuals with COPD have smoked in their lifetime. COPD impacts the quality of life of those affected. Individuals with COPD experience episodes of exacerbated symptoms. During these periods, lung functioning decreases and symptoms such as coughing and wheezing become more severe. The frequency and intensity of these episodes varies from person to person. Episodes may be triggered by infections of the respiratory system, environmental pollution, or unknown factors. Exacerbation can cause medical complications for these individuals, which may lead to hospitalization or even death. These individuals often have conditions which co-occur with COPD, which further impacts their quality of life. This includes high blood pressure, heart disease, heartburn, depression, and diabetes. Also, research indicates that these individuals have a higher chance of presenting with symptoms of disordered swallowing, known as dysphagia. In the article, Prevalence of Swallowing Dysfunction Screened in Swedish Cohort of COPD Patients, a study involving patients with COPD is explained. It is suspected that patients with COPD have difficulty coordinating the breathing and swallowing mechanisms, leading to oral pharyngeal dysphagia and ultimately aspiration. 51 patients with moderate to very severe COPD participated in the research while they were in a stable state, meaning that they had not experienced a period of exacerbated symptoms in at least 3 months. Participants filled out a questionnaire which asked questions about their current experiences and difficulties with swallowing. Then, the patients participated in 2 swallowing studies. The first was with water. The participants were timed to determine how long it took them to swallow water, as a typical swallow takes approximately 1 to 2 seconds. The examiners then listened to the participants speak, following the swallow, as a wet, gurgling noise is a sign that water has penetrated the airway. The participants then ate a cookie. Examiners watched as these participants chewed and swallowed and noted if the participants coughed at all during the assessment. Results of this study indicate that COPD and dysphagia are related. Based on the questionnaire and swallowing studies, 78% of participants experienced some symptoms of dysphagia. The article Breathing Swallowing Discoordination is associated with frequent exacerbations of COPD explains a study which further investigates COPD and its relationship to dysphagia. The study focuses on the coordination of breathing and swallowing of 65 patients with COPD. Swallowing requires precise coordination in order to get food from the mouth to the esophagus. When humans breathe, they inspire and expire air. Typically, when humans swallow, it occurs during the expiratory phase of breathing. It was found that these individuals were more likely to inspire during or immediately after swallowing due to having compromised breathing. The study found that those who inspired during or immediately after swallowing were more at risk of having a period of exacerbated symptoms. This shows the link between dysphagia and aspiration and the lack of coordination between swallowing and breathing that patients with COPD present with. The study concludes that it is important to assess patients with COPD for signs of dysphagia because swallowing difficulties may go unnoticed and ultimately can lead to exacerbation of COPD symptoms and decreased quality of life. In addition to difficulty coordinating breathing and swallowing patterns, patients with COPD are at risk for other factors which may contribute to them having swallowing impairments. In the article, Impaired Laryngopharyngeal Sensitivity, LPS, in patients with COPD, the association with swallow function, a study which was conducted in order to assess the relationship between decreased LPS and swallowing is described. The study involved 20 patients with COPD. Participants were examined for LPS functioning and respiratory functioning. Decreased LPS is associated with smoking. They also completed a questionnaire, swallowing examination, and a fiber optic endoscopic evaluation of swallowing, known as FEES. It was found that these participants had reduced LPS and had residue in the pharynx after swallowing. This residue was undetected by patients with reduced sensation and therefore never triggered an additional swallow. This puts these patients at risk for aspiration, as residue in the pharynx can leak into the airway. It was found that questionnaire results in the study differed from other swallowing tests. Many patients who did not suspect that they had swallowing difficulty actually did. This discrepancy is likely due to the fact that they were unaware of their decreased pharyngeal sensation. The literature about COPD and dysphagia provides evidence for the bidirectional relationship between the two conditions. COPD causes disruptions in breathing patterns, which contributes to difficulty with coordinating swallowing and breathing. Patients with COPD also tend to have decreased LPS, likely due to smoking, which can lead them to having food remain in the pharynx after swallowing, which can eventually leak into the airway. This causes aspiration, which can lead to exacerbation of COPD symptoms. Therefore, it is important for SLPs to understand the structures and functions impacted by COPD in order to best assess and treat them for swallowing impairments. Typically, when individuals swallow, breathing is paused for a few seconds. Then, following the swallow, individuals exhale. Individuals with COPD are less likely to follow this pattern. They may inspire during or immediately after a swallow, increasing their risk of having food enter the airway. Laryngeal aspiration is very dangerous and puts these patients at risk of exacerbation and can cause inflammation of the lungs, leading to health complications. These patients are at risk of malnutrition and dehydration as a result. Although the disease is mostly associated with the lungs, COPD is systemic in nature and can impact the entire body. Therefore, muscles become weak and fatigued. Some of these patients experience diaphragmatic mobility reduction, so they use accessory muscles to compensate for this. Their muscles become short and tense, and evidence shows that this can impact the quality of the larynx and pharynx as well. Additionally, These patients use a lot of energy when breathing and swallowing, since their lungs are compromised. Some patients with COPD burn many calories because of this, and since they are absorbing so few nutrients due to their swallowing impairments, they lose weight. Although many patients with COPD are at risk of having dysphagia, which can lead to complications like aspiration, it is impossible for every patient with COPD to undergo a full assessment. This is why quick screening and assessment measures are so important. An example of this is the Eating Assessment Tool 10. This tool can be used to quickly screen adults with COPD and determine if they are at risk of having dysphagia and need further evaluation. In a study conducted in 2017, 30 adults with stable COPD completed the Eating Assessment Tool 10, a self reported scale in which individuals can rate their experiences with swallowing issues. Then, a speech language pathologist conducted an assessment on these individuals using fees to see if their Eating Assessment Tool 10 responses correlated with their actual swallowing. The study found that the Eating Assessment Tool 10 accurately predicted those who were at risk of dysphagia. This is significant because this tool is quick to administer and can be used to determine which patients need further evaluation. These patients can then be assessed in order to see if they require dietary restrictions or therapy, or to see if they may need to be fed in alternative ways, such as through a percutaneous endoscopic gastrostomy tube or a PEG tube. For those who can benefit from therapy, the main goals are to coordinate breathing and swallowing and to work on maintaining muscle strength. A tool that is used for patients with dysphagia and can be used for those with COPD and dysphagia is high resolution pharyngeal manometry, or HRPM. This is a form of biofeedback therapy, which senses pressure in the pharynx and provides information in the form of visual feedback. It allows patients to visualize their swallow at the time it happens. For example, they can see that more forceful swallows elicit higher pressure. A study done with a 66-year-old man with dysphagia showed the impact of using HRPM. The participant had residue and decreased ability to protect the airway. He was using exercises to strengthen his muscles and some compensatory strategies at home, but had such a lack of sensory awareness that he was not making much progress. For 6 weeks, the patient used HRPM biofeedback to see his swallow in real time. The visual feedback helped him to learn how to swallow more efficiently. In conjunction with this therapy, he continued daily exercises, and he was able to have his feeding tube removed. He was recommended mechanical soft foods and thin liquids. This provides some evidence for this type of therapy and how it can help patients to modify their swallow in order to perform their best. There is also some evidence for using incentive spirometry in therapy. This involves the use of a handheld device, which is used to improve inspiration. The patient seals their lips around the mouthpiece attached to a chamber and inhales. There is then a visual marker, which indicates how much air has been inspired by the patient. This can be used in therapy to exercise the lungs and maintain function. In conclusion, COPD is a progressive lung disease characterized by coughing, wheezing, and breathlessness. COPD is linked to dysphagia, as these individuals have trouble coordinating swallowing and breathing. Additional research has shown that patients with COPD have decreased pharyngeal sensation, and residue is left behind after eating. This allows for food to leak into the airway and become aspirated. Having aspiration as a result of dysphagia increases the chances of an exacerbation period. Therefore, there is a bidirectional relationship between dysphagia and aspiration and COPD symptoms. It is important that individuals with COPD are screened for dysphagia, as many are at risk of aspiration, and this can lead them to have life-threatening complications. At this time, research on treatment is limited, but there are methods that can be used to enhance swallowing abilities. There are ethical issues which surround this topic, as patients who aspirate may be recommended to eat modified diets or even to feed through alternative methods. This can become an issue for patients and their families, as they may not wish to follow recommendations. Regardless, it is important to assess these patients, as their symptoms of dysphagia and aspiration are often overlooked, and addressing these issues can improve their quality of life.